I don't know why it stopped last time. Okay. And then attitude to infant feeding, maternal depressive, so very detailed information on the concept, and then the clinical assessment for glucose. So one of the main exposure is hyperglycemia in pregnancy. Very detailed what kind of test they use. So they use a test, oral glucose tolerance test between the week, gestation week 24 to 28. 3 blood samples were collected, so 3 at fasting 60 and 120 minutes. How many measurements, and how did they record that woman has gestational or glycemia or hyperglycemia. And then after discharge, how they collected the data on the outcome. So at the time of delivery, they had information about the baby, because one of the outcome is about the health of the baby. So they had the APGAR score, which is a score that tells me how the well-being, overall well-being of the baby when the baby is delivered. The nurse has a checklist, and that checklist ends up with an APGAR score. The higher APGAR score, 7 and above, it means the baby is in good health. The type of delivery, complication, all are usually recorded in the hospital. And they did a follow-up study to the woman's home at 1, 3, and 6 months of age, and they recorded symptoms like if they were hospitalized, infection, so on and so forth. So please, I do encourage you to just go over the method of this article to understand how they've done it. This is a well-done study. All the aspects that they have defined and described actually enhance the internal validity of the study. Very well defined exposure, very well done sampling, representative sample with analysis of respondent versus non-respondent, with some objective tests that they use and that are recognized. Based on that, for the gestational diabetes, it was confirmed, so on and so forth. So that's for the perspective. While for the, okay, so I'll close this. Okay. So okay, now for the retrospective cohort study of leukemia. Okay, so again, you recall for exposure that are rare, that will really require a lot of work to recruit, like specifically occupational cohort. Authors usually look at historical cohort. So to look at the effect of benzene exposure on leukemia and other cancer. So that was a retrospective cohort that was carried out in 1982. So the study was initiated in 1982, right? And they took benzene worker, exposed benzene worker in 233 factories, and they took a control worker from other factories in 12 large cities in China, but they are we know that they are not exposed to benzene. And then those workers have been employed in those factories from 1972. So they identified the cohort in 1972, and they assessed their health in 1982 and 1983 and beyond. So it means that they look at those workers. It's a 10-year cohort, as if they have followed up minimum 10 years of the cohort, which was initially started in 1970, not by the author, but they took this cohort as all employees who were working in benzene factory in 1972, who have record, whom we know the exposure, and then they took another group of workers that do not have exposure to benzene. Okay, so it is a retrospective cohort. Okay, so my question to you, what should what kind of minimum information we need in order to do such kind of retrospective? What are our concern in retrospective?
That to have enough information about the exposure.
Yes, to have enough information about the exposure. And so enough. Enough, what do you mean? Enough is not a good answer, Rula. Enough
Has to
Meaning the amount of exposure, the duration. Maybe they have each one depending on what their role was in the factory at the time. They would have different
okay.
levels of exposure to
Yes.
benzene. So
So
these
I
are
need
important to
detailed,
know.
so I need detailed information on the exposure. Yes. Okay, whether it's documented or not. So one is what kind of exposure do I want? Maybe they have monitors, maybe they do monitor the level of benzene, etc. So one. Two is to have complete information on this. So at least they have good record. So you have to have a good record kept in order to extract those information. And then two, so this is one is the exposure, the completeness, accuracy that we have it. Two, Noor, Janine, any thoughts? So do we collect only data on exposure?
Also data about covariates, possible
Oh, good.
confounders, yes.
Okay, excellent. So we need to know something about first other employment also information. How long have they have been? Okay, so how long have they been exposed as well? This is part of the exposure, but others like their age, gender, if they have any other diseases, right? If they are smoker, if we have any kind of information that could be a confounder. We're looking at leukemia and cancer, right? So this is another issue. And now, given that now we have the data at baseline from that retrospective cohort, so these are Lanul and no, they have well kept record. We have all the exposure indicator that we want. We have defined, of course, there should be a minimum of employment in the factory to be able to be part of that study. So then what we worry about, Busola or Tasneem, what do we worry about in the retrospective cohort? So now, so I went back 10 years and I checked the record and I was able to establish that historical cohort. Now I want to collect data on.
The outcome to make sure that
Outcome.
they don't have the outcome.
Okay, great. So what do I need to measure the outcome?
I think we have to make sure that the period which has passed is enough for the outcome to develop.
Okay, all right. Okay, so header one, two.
We need to have valid instruments that could measure the outcome.
Yes, and with the valid measure instrument, where to find this outcome? What do I need? I need some kind of a linkage, right? I need to have some kind of a linkage system that link that person to his record, either in the civil, in vital statistics, or in registry if registries occur. So I have to have a good tracking system. And imagine us, we have a factory, a new factory of Sanita, and then I want to follow up. So people who have been working in one of the largest factory in Lebanon, and I want to see what happened to them after 30 years of employment. How do I trace them? How do I trace them? I have to have enough and for a good system to trace those people, what happened to them. You are not following up yourself and making sure you are retaining them. لأنه prospective, you control. Of course, they will be lost to follow up, but I mean, you call them, you have their numbers, you try to keep in touch with them. But those people who have been employed, you have to try to find some kind of a linkage system that link those people to their outcome. So if you can get in touch with them and call every single one to see if they have developed cancer, self-reporting, fine. But usually this is not done. Most of the retrospective cohort do trace the outcome will be cancer or death. Cancer or death meaning you have to link them to the cancer registry by name or ID number or whatever, or link them to the death certificate. Okay. Again, I also encourage you to write it. So what kind of comparison group we used here? Within the benzene factory, you can always compare within those 233 factory, you can always compare those who were exposed to a certain level versus who are exposed to higher level, right? But they also have an external group, so they compared the cancer they compare all the outcome of those who are in benzene to an external group, which are a number of factory where there is no use or production of benzene. So this is an external type of control versus within those who are in the factory, you can compare them to each other based on the level of exposure, or maybe they are not at all exposed if they have an admin position or supervisory position, and compare those all in the benzene compared to the external. And of course, this will affect usually the analysis, and it's a design choice, but also it will affect how you analyze when you have an external comparison group. Okay. And if I want to open it to see, okay, so again, exposed, unexposed for them were exposed in the factory versus unexposed in the factory are those from others. The factory and hospital medical record were the source of information about history of benzene poisoning, aplastic anemia, leukemia, and other malignancy, but they as well look at, they interview next of kin for those who died. They mailed questionnaire to family member. They sent, so they had so many. If you read the method, and I encourage you again, because this is how you learn how people do things. I encourage you to read the method section because it goes into the detail where they got their information. It's true, it's a 1980 study, but it's also well done. I'm sure that you will find some flaws that might affect the association, but in general, it's a well done art study. Okay, they also define what are the leukemia they define them based on, I think, ICD code. They look at histopathology, clinical lab parameter to look at malignancy. Okay, so I think again, for the sake of knowing, because ultimately we'd like you to design. You will not be designing a cohort, probably you'll design in another course, but I think this is very important to read how people have done their studies. Any questions on the two article? Any question on the design? Do you feel comfortable with the design of cohort study? At least some, like you learned some particular issue that you need to keep in mind when you design. It's not an issue of only, it is a cross-sectional study and I'm going to do one-time survey. It's many more aspects of the study that you have to keep in mind when it's a long investment, it's a long commitment, because it's not about establishing that cohort, but it's commitment to go back to the cohort to collect data. When, what, how is very important. Good? We're good?
Yes, very good.
Okay.
Thank you.
Okay. Tap. Now, okay, so you have your, okay. So we have one article, which is let me share my screen again. Change the screen. Zoom. Sorry, Zoom. Okay, share. Okay, so on Moodle, so we have, okay. Check. Okay, so I want you to go over the application of cohort. Okay, so 1038. Just read quickly the smoking and Alzheimer, the Rotterdam study. Okay, 10 minutes. So now, we are at 1038. at 10:45 actually. You will have to stop. And then application is very short. Okay, just look at okay. We have few questions for the application. You can discuss them over. So all in all, 10:35. You can stop at 10:50. Okay, and then we'll have a quick look at the analysis, and you will yourself answer the application on hepatitis C and hepatocellular carcinoma on the Moodle forum. Okay, so I repeat, please, I will divide you into groups of 2 randomly. You can read for a few minutes the smoking and Alzheimer, the Rotterdam study, try to answer or address the question in the application, and then I'll go over quickly the issues of analysis, and you will do the application cohort, which is short. Later, I'll give you like a week time to read the hepatitis C and hepatocellular carcinoma and ask and answer the question, at least one of the questions, and then I'll post the key. Deal, is it clear? I'll send all these instructions shortly. Okay, maybe now I'll send them in the email. Okay, Tabiella, quickly I'll take out the rooms. Create, you are 9, you are 8, so 4 rooms. 4, assign automatically, create, open all rooms. So we'll be back at 10:50. Abdulrahman, can you join please room 1? Abdulrahman, please, can you join room 1? And Busolab, room 3, please?